And good afternoon, ladies and gentlemen. And welcome to the first of what will become a regular series of webinars from the Royal Society of Medicine as part of our new series on COVID for health professionals and by health professionals. So during this, please use the Q&A button on screen for your questions. And you can also vote for the questions that we'll try and answer as we go along by using the thumbs up function. Words I never thought I would say. Now, our first guest today is Dr. Rachel Clarke, Dr. Oxford, as she's known, to over 100,000 Twitter followers. She first came to national prominence, I think it's fair to say, during the junior doctors dispute, which seems a long time ago now, an almost innocent time really, when we were talking about protecting doctors' pay and their hours. Now we're talking about even protecting their lives. Now, since then, she's written her first book, Your Life in My Hands, and then her second book, Dear Life, which is about dying. Now, a specialist in palliative care, she says in her book, dying is now my day job. Rachel, welcome. And to kick off, I just want to kick off with what you wrote in The Observer last weekend. As the coronavirus spreads through the British population, there is one fact we can all agree on. Whether we like it or not, society's greatest taboo, death and dying, has been thrust unequivocally onto the centre stage. Explain.
Well, hello, Simon, and everyone tuning in. Yeah, absolutely. I think that's true in a really profound sense. In my experience as a palliative care doctor, it's really hard for most people to consider our mortality, even at the best of times, the most calm and placid and least tumultuous of times. And of course, right now is the very farthest thing from that. We are going through the most shocking upheaval probably any of us, or certainly the vast majority of us, have ever been through in our lives. Our entire society is locked down, and there's no escaping the fact that there is a new, invisible, silent threat that's seemingly in the air around us. Anybody could be infected, even if they're not displaying symptoms. And that's incredibly hard for everybody, because it means that we can't really avoid thinking about our mortality. We're hearing those daily statistics. They're going up, not quite exponentially, but rapidly every day. We probably all know people who are infected. Maybe by now, many of us know people who have succumbed to COVID-19. And so we're in really uncharted territory right now. And there's no escaping the fact that our fragility, our frailty, our ephemerality as mortal creatures is indeed centre stage.
And how do you think we should be responding then to that? I mean, we know that, the latest figures, the audit of intensive care shows that those admitted to intensive care, the last audit is 50% will die. How should we respond to that? First of all, not so much as professionals now, it's just everybody in the population, which all of us are. What do you think we should start be thinking about?
Yeah, I mean, and absolutely, I think this is a question for all of us as human beings, not irrespective of our profession, whether we're healthcare professionals or not. I think it's really difficult to face up to the very tough decisions that we all need to think about right now. The idea of losing our lives requires us to consider this enormity of every single thing and every single person that we love in the world potentially slipping through our grasp. So of course that's hard to do. Of course, on one level we long to flinch away from that. I would suggest though that precisely because we're in these very daunting times right now, it's never been more important to do what we as healthcare professionals would describe as advanced care planning. So this is the effort to reflect upon and chat with your loved ones about what level of medical care, what intensity of level of medical care would you wish for if the very worst happened, and if you became sick enough with coronavirus or any other illness potentially to need intensive care, a ventilator to breathe for you, and so on. the reason it's so important to think about this in advance is if we don't, we may end up in a situation all of a sudden in very panicked circumstances where either we or one of our loved ones is rushed into hospital, and suddenly you receive a phone call from the consultant in intensive care saying, look, we have your mother here. We need to get a sense of her wishes. She can't tell us herself. Would she want to go to intensive care? Would she want a tube into her lungs to breathe for her? And there's nothing more heartbreaking in that situation to realize that you simply don't know the answer, and you have to say, I don't know, we've never talked about it. How much better to sit down, make a cup of tea, and have a calm chat about it now, so you actually know in advance what your mum or your dad or your brother and sister would wish for if the worst happened. And it doesn't need to be technical. There are technical versions of these conversations. So we will sometimes help patients complete so-called advanced treatment directives, but actually anybody can have these chats with one another, and you have the advantage of being prepared.
Rachel, already a lot of questions are pouring in. See Claire Jonas, Nicola Fair, many others are saying, what I think, paraphrase them all, is saying, but how can we do that when we're in lockdown and my elderly mother, I think that's Claire speaking, I'm not able to get access to her. It's all very well saying that when we're on the sofa together with a cup of tea, but how would you start these conversations in this world of COVID?
Yeah, well, and this gets at, I think, one of the particular cruelties of this illness, because it's an infectious disease. We are separated from each other, we're separated from our loved ones, and sometimes that means the best circumstances for this kind of difficult conversation, which is always face-to-face, calmly, with a rapport and intimacy between you, we're denied those. What I would say to try and encourage members of the public is, in my experience in palliative medicine, these conversations so often do not measure up to people's worst fears of how difficult they're going to be. So doctors, as well as ordinary members of the public, sometimes find it really difficult to talk about death and dying, to sit down with a patient and broach the fact that they may not survive, and therefore it's important to find out what their wishes are regarding treatment. But actually, in my experience, I would say the overwhelming majority of patients and families with whom I have these conversations do not find them traumatic, and sometimes, often, in fact, they find them a form of relief, because actually everything is out in the open, and the one way to make things feel more scary, more daunting, is to suppress them, is to keep them under wraps. So I would suggest, if you've managed to get your mum or your dad, say, hooked up to Zoom or FaceTime or WhatsApp or whatever form of communication you've got, preferably with a video component so you can look at each other, but failing that, audio, I would suggest trying to broach the subject gently, but actually honestly, and saying the obvious things. I'm really sorry to raise this, mum, and I really hope that I'm not going to cause anxiety. We know that the vast majority of people who get this illness are not going to be seriously ill, but I have to ask the question, if you were unlucky and did become seriously ill, do you have any idea what you would wish for? Would you want to go to hospital? Would you want to go to intensive care? If you do that calmly and honestly and with compassion in your voice, then you are conveying how much you love your relative, but you're still broaching the difficult subjects. And I think that's the only way to do it.
Antonio has raised the issue. Yes, all of this is directed towards what you might call the more traditional models of palliative care and end-of-life decision-making. But I think he's working in a maternity unit and says, how do we initiate these discussions where this really isn't part of the almost not exactly expected, but familiar grounds where you're working? So how would you do this in a very unfamiliar setting?
So there are some fantastically good resources now out there to help guide people, and I wonder if perhaps the Royal Society of Medicine can maybe post some links to some of those perhaps after the
Absolutely.
webinar, rather than me going through them now. But I'd suggest lots of different organisations, including the Association for Palliative Medicine, have given some really good practical guides for this. So why don't we
will be posting some links when we send out feedback to that, and some other guidelines on some other decisions as well. So let's then, I know a lot of people are now asking as well about how palliative care is working at the moment. I mean, if I can just quote from your own book, which by the way, I have now read and could not recommend more. You talked about, you know, this is before COVID, your mother, your mother-in-law, Pat, who developed sepsis and basically died in 96 hours from when you heard the news. But in that short period of time, the palliative care team made an amazing difference. And you talked about how armed with not just their expertise, but the conviction that even, perhaps especially in the last throes of life, superlative care is crucial. Medicine is very best placing patients, not disease, center stage. Now, fantastic, and I had the same experience with my mother. But at the moment, can we honestly say the patient really is the center stage of palliative care at the moment? What actually is happening in your service and others, Rachel?
So I'm the kind of doctor who always likes to try and answer questions honestly. I will never sugarcoat things because I just don't think that's an effective way to build trust with patients or the public or anyone. So I'm going to answer that honestly, Simon. There is no denying the fact that the restrictions on visitors at the moment, which apply in all our hospitals and all our hospices as well, are making it incredibly difficult to provide the normal high quality palliative care that we would to patients. And that is because a crucial component of palliative medicine is facilitating, enabling as much as possible the presence, the warm, intimate, physical presence at the bedside of a patient's loved ones rather. And that's because when you are potentially facing the end of your life, there are really two sets of enormous challenges. One is the physical symptoms, and actually we're pretty good at managing those. In coronavirus, we're finding it very straightforward in many ways to manage the symptoms. The main one is breathlessness, and we have really fantastic drugs and so on to manage that. But the other set of issues is around the, in a way, psychological or existential aspects of confronting the end of your life. And there is a great fear and a great loneliness often that people feel as they approach the end. And for that, the key drug is not morphine, for instance. The key drug is a human presence, ideally the presence of the people you love. And that may manifest itself not only in the human beings at your bedside, but pictures, writing, all your favorite duvets and so on from home, all of those things that make you feel surrounded by love. And that's what we can't provide at the moment, except in very rare circumstances. So it is the case that most hospices, most hospitals are trying to facilitate the presence of one loved one, if possible, at the bedside of someone who is dying, whether from coronavirus or another illness. But it's not always possible to do that because the safety precautions around the infection have to take center stage. However, that's the bad thing. But the really important thing to stress is, and I don't mean this glibly or lightly at all, even if you cannot be there, firstly, we will do everything we can to get you there virtually through Zoom, something like this, so that you can communicate. If you want to record videos or write letters, emails, we will read them out to your loved one. It's not the same as you, but we will do that. And crucially, every single person working in the NHS, every single doctor, every single nurse cares more than you could ever imagine about the importance of ensuring that these poor individuals who are dying from coronavirus receive the very best substitute love and care at the bedside that we can provide.
There are 3 or 4 questions all asking the same thing, which is, in your own service and what you know of others, are there now adequate supplies of PPE equipment?
Again, I'm going to be completely honest about this. I would never lie about anything. I can tell you that the hospice sector in particular is suffering terribly badly at the moment from lack of supply. So some of the people tuning into this may have seen really desperate pleas from some of the hospices in London, for instance, literally begging the public for the masks, the gowns we need to stay open. My own hospice, a wonderful hospice, Catherine House Hospice in Oxfordshire, we have literally just had to beg all of our local veterinary outfits, the local vets, for masks, because vets.
You mean vets? Okay.
And we actually were very, very seriously wondering whether we would be able to stay open beyond this weekend, because we simply haven't been given the simple paper masks that we need to stay open from NHS England. However, I'm absolutely delighted to say we've managed now to get from a charity a bulk order of masks, which is going to keep us going in the short term. But that's an incredibly precarious and tenuous existence. And I think it's really important to state that in this pandemic situation, of course, we want to be focusing resources and efforts on saving as many lives as we can. But we know
Stanley,
die. And in a sense, I do feel as though currently the victims of coronavirus, the people who are not surviving it, have actually been somewhat neglected in the planning so far. It's not right that hospices are begging local vets for the masks they need to stay alive.
Are we able to provide, as Linda has asked about providing PPE for at least one relative visiting? Are you able to do that now?
Yeah, so any relative to visits will need to wear a gown and masks, and we will supply those, yes.
Okay. I mean, what we're coming on to here is obviously, you know, your amazing plea for patient-centered care, which I know palliative care delivers, is suffering in a public health emergency in which population needs are prioritized over that. And it's not just patients making choices, it's now staff and doctors having to make what previously would have been inconceivable or hard to conceive and unpalatable choices. Let's switch then to the general situation outside end-of-life care, or at least, outside palliative care settings. You're doing sessions now in emergency departments again, aren't you? Is that right, Rachel?
Yeah.
You are doing ED sessions.
Yes.
Yeah. So people are asking about, you know, what's your experience and what should we be doing about now thinking about the choices that people like you, not people like me, people like you are having to make. And this Nicholas Stringling is asking this specific question of, do you feel that you need guidance on this issue? I know there are various types of guidance around, but no official guidance covering the whole of the service. Do you feel that that is necessary, or do you feel that people are managing in this extreme situation?
So this is an issue that I think has created an enormous amount of stress and anxiety and fear among the British population, not helped actually by some very, very irresponsible reporting, even from some of the broadsheets on this matter, where, you know, the sensationalist headlines about doctors rationing care, you know, can get in the way of actually the facts and nuance of this issue. Also, we know, of course, some of the terrible decisions that have had to be made in Lombardy, which is the epicenter of the Italian coronavirus outbreak, where some hospitals have had to ration their care in a very brutal way. So in some hospitals, there was a cutoff, for instance, of age 65. If you were over 65, you wouldn't be considered for an ITU bed and a ventilator. And that's pretty shocking to consider. It's not, I don't think it's quite accurate to say that we don't have national guidance. So NICE, the National Institute for Clinical Excellence, has published national guidance on how the incredibly important dilemmas and judgments around who goes to critical care and gets a ventilator, how those should be conducted. And the really important thing is that decision-making should happen in a way that is fair and equitable, and no group is systematically discriminated against, for example, because of their age. So you could be 25 and incredibly frail because you have 6 underlying serious illnesses, or you could be 70 and run up mountains every day and be fighting fit. And so one of the key factor that underlies this decision-making is your frailty. So your frailty is important because it is linked to your chances of surviving. And one of the ways of trying to figure out these decisions is to ask in an objective, calm, dispassionate way, given this individual in front of me and all their frailties or lack of frailties, how likely do I think it is that they will benefit from intensive care and survive?
Now, Louisa Pollitt's asked a very penetrating and possibly impossible question, but we're assuming that many people will make advanced care directives that they don't want to die alone. They would rather stay at home and take their chances. What if someone who is in a very high risk group, their advanced care says the exact opposite? They definitely do want to go to be intubated, to have the whole panoply of modern medicine. And yet the kind of heuristic algorithms or that we're using, whatever they may be, whether official or unofficial, would suggest that that's not going to happen. What happens when there's a conflict between that kind of ACD and what is actually available? I don't know if you can answer that question actually, but what are your thoughts?
Well, I think, I actually think that is a dilemma that is not in any sense unique to the pandemic situation we're in now. In fact, that dilemma is, in a way, the bread and butter of ICUs up and down the country most of the time. So we will often encounter patients who desperately want all treatments, everything, and they don't care what the risks are. They just want to live. And, you know, I could imagine myself being in that category. I have children. I want to live for them. I would be screaming, please give me everything. I don't care how toxic it is. If it saves my life, I want it. In Britain, ultimately, the decision whether or not a patient receives a particular medical treatment is a best interest decision made on the part of doctors. So in this country, you are not entitled to receive a treatment because you want it. Ultimately, your medical team are the ones who will make that decision on your behalf, even if it conflicts with what you actually wish for yourself. And sometimes, of course, we end up with these conflicts going to the High Court and being adjudicated by the judges. That actually happens all of the time. And intensive care beds are a scarce resource, and intensive care doctors are having to weigh up every day in the NHS who they think is most likely to benefit from a bed, because if you don't do that, very, very quickly your intensive care will be filled with people who are preventing other people from taking the beds. And if none of them survive, then all of a sudden you may end up with a mortality of all the other people who never got the beds who might have survived. And that's one of the reasons why intensive care is such an extraordinary specialty, because the men and women in those jobs are making those decisions every day.
Okay. I mean, in the last 24, 48 hours, there have been guidance issued by both the BMA and the Royal College of Physicians, and I know many hospitals, my own included, have developed good guidance as well. But the National Clinical Director did duck the issue at the Downing Street conference and said, we will rely on doctors, that this is business as usual when it comes to end-of-life care, which I think is a little ducking the issue. Now then, I'm getting quite a few questions saying you, of course, are very well known for your leadership during the junior doctors dispute, and they're saying, how do you think, I'm paraphrasing 3 or 4 here, but how do you think now junior doctors, how in the post-COVID world, how would we look back on this kind of baptism of fire, as it were, during the age of COVID? What do you think? How do you think this is playing out? You probably know better than most.
Well, it's interesting because in no sense am I going to try and pretend this is a good state of affairs. It's a positive state of affairs. Clearly, like everybody, I dearly wish this wasn't happening, but it is. I don't think it is wholly negative at all, though. And I was thinking about this morning when I was reflecting on the word apocalypse. You know, lots of people are talking about the fact that we're living through apocalyptic times, you know, absolute catastrophe and new unprecedented loss of life and so on. But apocalypse, actually, if you look at the etymology of the words, it means revelation. And I think that's really interesting, this idea that through these apocalyptic times, important truths are being revealed. And I think that many junior doctors, and perhaps all frontline, and not just frontline, sort of backline NHS staff, we are all finding these times revelatory. The NHS is a huge, unwieldy machine. And as one intensive care consultant put it on Twitter recently, it's a bit like a hippopotamus. It lumbers slowly and clumsily, but when it really gets going, it can stampede fast as you like and kill more people than any other big animal in Africa. And actually, I think that's true. That's the revelation. In the last few weeks, we have all seen the NHS moving like lightning because the conditions are so extreme and so urgent right now. My hospital, for instance, has been completely reconfigured from the top down. We have 12 medical wards to care for coronavirus patients that didn't exist 2 weeks ago. Everybody, or most people, are doing different jobs. Everything has been transformed. And I think as a junior doctor, it is inspirational and extraordinary to see not only what the NHS is capable of, but also this incredible outpouring across the NHS and across the country as a whole of all the very best bits of human nature. So our determination to fight for each other, to do what's necessary for each other, to rally together, all of us to help in the little tiny ways we can, whether we're a doctor, a nurse, a bin man, a delivery driver, it doesn't matter. Everybody is showing the very best of human nature. And I think that is inspirational. And I think that is going to endure long, long after this pandemic is over.
Okay. There are many more messages coming in particular, still a lot of people concerned about PPE for carers and relatives, and a lot of people also concerned about going back to how do I start this conversation with my isolated relative who I can't see? Do you want to just go back to that? Because I think that seems to be one of the biggest issues. What tips do you have for how do you broach these how do you start these conversations? You do this all the time. Most of us don't.
Yes. So a couple of tips. So as well as the setting being important, so if you can, try and do it with a video link, not just over the phone. Try and think about your vulnerable loved one. When is a good time of day for them? When are they sort of at their best? Is it the morning when they're not too tired? When is a calm and peaceful time? So get the setting as good as it can be. And then another crucial thing that we always try and consider as health professionals is try and find out, get a sense of what the patient, or in this case your relative, what they already understand about this issue and what their views are already about it. So rather than diving in with what you think is important to discuss, maybe talk more generally in an exploratory way about, Mum, what do you think about what's happening? Are you worried about the numbers of people who are dying? Do you have any views about that? And you may be surprised, because you may discover that your mum or dad actually has already been thinking about it themselves. They already have views on it. And it's easy to fear that by broaching the subject, you are going to cause harm, you are going to distress your loved one. But actually, you don't know that that's the case. Even now, as an experienced palliative care doctor, I sometimes worry that if I raise, for instance, the fact that an illness is terminal with a patient, it may distress them. But so often I'm surprised, and the patient may say, I knew you were going to bring that up with me, doc. I've been thinking about that myself. I'm surprised it took you so long. That kind of thing. So find out what your relative actually feels about this first, if you can, in an exploratory way, and then don't assume that by getting something out in the open, it is necessarily going to be painful. You may be surprised. You may find it's actually a relief for your mother, father, loved one, and a relief for you too. And also, crucially, I think these conversations are not just an opportunity to find out what your loved one wishes are, they're also an opportunity to say really simple, vital things that we cannot say too often right now. So you can say, Mum, there's one thing I want you to know more than anything right now, is how much I love you. What a wonderful mother you are. And I'm always crying myself thinking about that now, because I've been having conversations like that with my mum. You just tell them all the things they need to hear about why you love them, and make sure they know how loved they are. And that's it. That is the most important thing. What we have in a pandemic is each other.
Yes, well, I couldn't agree more. Several people have said, can't the RSM bottle Rachel and distribute her right across the NHS? And someone has said, she's the doctor I want when I'm at this stage, and I couldn't agree more. Now, most of the people watching are clear from the questions are full-time practitioners. So we said we will finish, so we will finish. And first of all, I want to thank you so much, Rachel. Advise people to please read your book. I suspect we may be hearing from you again. We will be linking to some of the websites that have been mentioned with advice. We will be continuing this series of COVID-19, I'm still not sure if it's COVID or COVID, seminars, which will be the next one. They'll be at 12:30 next Tuesday and next Thursday. We're expecting to hear from some very distinguished frontline clinicians. We're still juggling diaries with difficult people, but expect Peter Oppenshaw and Hugh Montgomery and David Haymans will be on in the next few. And then on Wednesday in the evening, we'll be switching to a rather more longer conversational type format that we've done live before at the RSM. And as soon as he finishes the PM program, we will be joined by Evan Davis for an hour in conversation on what life will look like after COVID. So thank you, Rachel. Thank you everyone for watching. So it's goodbye from us. And in the words of Sergeant Pete Esterhouse at the end of the Best Cop Show series ever, be careful out there. Thank you very much.